I will make my presentation in Turkish to be more practical. First of all, I'd like to thank the organizing committee for organizing this session and for inviting me to this session. Well, there's a laser pointer that I want to use. Depression continues throughout the life. It starts at the womb of the month, and with the stress of mother there are epigenetic changes, and then followed by some other changes to be presented as a disease. There are two important factors, one of them being genetic factors. Nearly it helps us to explain 40% of the factors, and then environmental factors, which explains 60% of etiology in the general population. During adolescence, or adolescence is very interesting because with younger ages, genetics are more effective, but with older ages, it means there are more environmental factors, but in adolescence, it's a mix of environmental and genetic factors. There's a study performed in Denmark containing the whole population for 10 years, 13 years, 350,000 mentally ill patients' prevalence and incidence were looked at, and it was identified that, especially in females, depression or mood disorders are the highest between ages 18 to 30. Between 15 to 16, depression is the most prevalent if a risk factor is there. This study was performed in 1990s, so the age of 15 was a cutoff point for females, and after the age of 15, which is also supported by our own data, and in other studies, mean age is presented as 15. So after the age of 15, the prevalence is increasing fastly, and that rate, that amount is there, continues for longer times when compared to men. There are risk factors, female risk factors, but the most important reason behind its occurrence in the elderly ages is the brain development, especially in frontotemporal regions, in the frontal cortex of females. It becomes mature during adolescence, before the boys. So thinking about these changes, and they occur at earlier ages when compared to earlier ages in women when compared to men. This is the case for us, for practitioners. The transition period is very important. It starts at the middle of that period, but with the age, with the increase in the age, after 15, 16 years of age, it is increasing. But hereditary factors are important. Subclinical depressive symptoms, gender, early adverse events, current stress, illicit drug use, and anxiety are important factors. But for some other people, they may not be presented with any of them. So less than 5% of them, if there is no risk factor, then we may see depression in women. So the transition period is significant. If we can understand that period better, then it would be possible for us to understand the disease, the illness better. So in adult depression, we have to look at adult depression first. We have some good findings, one of them being the deteriorated reward system. That system doesn't function very well, both in fMRI studies and other psychological studies. Expectation of reward and namely wanting and liking, or while consuming the reward, the liking, there are problems. Another factor is related to amygdala, especially when there are negative and threatening stimulus, like a sad face. Amygdala activation is higher. So this finding is there in many different studies. There are other symptoms as well. Oversensitivity towards decline or refusal. But these are the most common two areas. In adolescent depression, this is nearly the same, or the situation, let's say, is similar. This is a good study. It's an old one, but the results are similar with the upcoming ones. There is an fMRI task. First, we want the patients to make a guess and guess whether that number is smaller or bigger than 5. It's like a rough guess, but after that guess, there's an expectation of reward. So if he wins, he gets $1. If he loses, then he loses 50 cents. So there is a wanting, and there is also a consuming, or there is an outcome. So we see the anticipation and outcome. In depressive cases, in adolescent depressions, patients, both while waiting and while consuming, their striatum was less than the normal ones. But in medial prefrontal area, there is an increased activity, which is higher in depression cases, both at the time of wanting and at the time of consuming. So this part of the brain identifies the value of the reward, so the changes in these areas are important. Another characteristics of this study is the ecological momentary assessment. Before fMRI, for 4 days, children actually record their moods in the stimulus they received by their mobile phones, their smartphones. So we also see that there is a correlation between the joy they got from this stimulus, or we know that adolescents are aroused more difficultly, aroused in a difficult way when it comes to a reward, or they are evoked very easily. Is there any change during adolescence? During early adolescent periods, striatum's response is not too bad. It's slightly high. However, with the midterm of adolescence, at the age of 15 or 16, its response to this stimulus is correlated with unhappiness. So we know that at the beginning of the adolescent period, children's striatum and the activity is different. They are happier. However, striatum activity decreases by age, and they feel less joyful. How about the risky ones, the risk factors? Both during anticipation and when she receives awards, striatal activity is less. The risky ones, even before depression, have lower striatum activity, but at the beginning of adolescence, striatum activity is good, but towards the middle, the activity gets lower. So adolescence, striatal activity is normally high, but through the mid-adolescence, it slightly reduces, which is not related to depression. However, in the high-risk group, it's already there at lower levels. What's interesting is that if there is a childhood trauma in the early period, then this deterioration in striatal activity, it's not presented in the early adolescence, but at the late phases of adolescence. When fMRI is performed within 2 years apart, in children with childhood depression, in the first period, there is no striatal difference, but after that, after some time, there is a difference. Now, what are the predictors of depression? Through the mid-adolescence, if there is decreased striatal activity, it gives us some prediction of depression. But in boys, there is an increased media prefrontal section. It shows us the risk. This is, in this study, 140 young girls were included and followed up for 18 months. And at the start of the follow-up, they perform a play game, a door game. They say that which door will be opened, right one or left one. If they win, they get $1. If they lose 50 cents. There is a reward negativity, as you can see in the green section. And if you lose, there is this activity when you see with the red color. When these activities, when winning and losing wavelengths are studied, the amplitudes are studied, the difference, this is the ones who were depressed in the following time. Their reaction to reward is lower, but their reaction to loss is higher. So, those who are not in depression is there, and you can see those who are in depression. So, even people before they are depressed, they have a reward negativity. I'm speaking of girls. We can see whether they will suffer from depression or not in the future. So that reward positivity also predicts some other dysphoric criteria too. However, the power of predicting reward positivity and the latter one are different from each other. So they have no interaction. So it means that they are functioning with two different mechanisms. On the other hand, amygdala activity, this is, we know it from Ahmet Harari's works, that they show negative faces. And if we have more faces, we see happy faces and we see scared faces. I cannot see it from this angle, but I want to see them. I want to change my position. I have to see which one is the patient and which one is the control. This is our patient, and amygdala activity is high when scared. But in control group, their activity is lower. Children with high risk who are not yet in depression and whom we predict that 50% will be in depression, we see an increased amygdala activity both in the right and in the left. And there's the happy face activity. In amygdala, there is no significant difference, but nucleus accumbens is significant in the reward one. So normal children and adolescents have much more activity towards the negative when compared to the other group. So there is higher increased activity in negatives and decreased activity for positives. This slide shows us how 50% do not suffer depression although presented with risk, and the remaining doesn't suffer from depression. We made a comparison between these two groups, youngsters between 18 to 24 years of age, girls, I mean these are girls, presented with depression risk. We looked at the differences in their brain to see which areas are more protective. 23 depressive cases, they have more than one episode, around 3 episodes. At least one person was suffering from depression, mainly that person was the mother. And there is the intra-episodic period. We also planned remission too, but it's not easy to find patients in remission. And there's a high-risk group, girls, 25 girls. They haven't suffered from depression and no history in their family. There is no difference in their brain volumes, but the scores, BDI, TAI, SAI, are higher in that group. What's the difference? Interestingly, amygdala in non-depressed but risky group, amygdala volume was bigger, and there's a difference in insula, but we were not interested in that. That's not, I won't dwell into that. When we see it with graft theory, amygdala's regions, there is a significant association loss. So a bigger amygdala prevents people from suffering depression. There is no sufficient number of studies, but in one study, when the high-risk group and when they have that disease in family history, there is a reduced amygdala volume. So in literature, for the first time, we have come up with some overlapping cases. Normally, this is not the case. So in the no illness group, or those who are not suffering from depression, the results, the outcomes are different. So when we look at amygdala nucleus, we checked them one by one. This was done in free surfer, and in certain nucleus, the size has a reason to be that big. One of them is basal nucleus and accessory basal nucleus, which you see in orange color. Nucleus is in red color. And amygdaloid, anterior amygdaloid is in the anterior portion, shown in yellow color. And there is corticoamyloid transition zone, which is depicted in dark blue in the anterior part. So all these regions are associated with prefrontal cortex. So amygdala is directly associated with prefrontal cortex. So the bigger these nuclei are, as we can see from that picture, will prevent people suffering from depression. But with depression, it seems like amygdala is shrinking or getting smaller. In this fMRI study, in high-risk women, what happens in emotion regulation is checked. In the left amygdala, there was a significant increased activity. It's growing bigger and the activity is increasing, which are helpful. So in conclusion, the reward system in people prone to depression or adolescents prone to depression, even before the disease occurs, is deteriorated. And this contributes to find out depression. And some early stress factors, childhood trauma, and early negative factors create a change in the reward system, which can be observed in the later period of adolescence. Amygdala volume change in high-risk groups is not changing or increasing, let's say, and this prevents transmission. So there is a neuroplastic change. So when compared to control groups, we can speak about increased amygdala volume. So increased amygdala volume has a protective effect, but with the reduction of the, so using more than one markers provides better predictability. And we shouldn't forget that reward system itself is not a reward system alone. It has so many characteristics like prediction error, or it helps us to identify where we made mistakes or made wrong decisions or not. Thank you very much for your attention. I would be happy to answer your questions. Thanks.